Good afternoon. My name is Dina Pimenova. I'm the Senior Project Coordinator for the NYU Langone Community Health Worker Research and Resource Center, housed in the Department of Population Health at the NYU School of Medicine and supported by the NYU Langone Community Service Plan. On behalf of the CHWRRC and our co-sponsors, I want to welcome you to the first panel session of our second CHW Innovation Summit with a focus on new frontiers for establishing a health equity workforce. Next slide, please. A little housekeeping before we get started. Due to the nature of this being a Zoom webinar, everybody is on mute. To enable or disable closed captioning, select live transcript at the bottom of the screen. The chat box is open for comments and sharing of resources. Please make sure to select everyone, not just hosts and panelists, when using this feature. And please use the Q&A box to submit questions to the speaker. We will have time to answer as many questions as we can during the Q&A portion. The slides and the recording will be made available at a later date. And lastly, please be sure to complete the survey at the end. Next slide, please. Before I pass it on to our speakers, I'd like to give you a quick preview of what to expect over the next 2 days. Following this panel, we will hear from speakers discussing New York City Department of Health and Mental Hygiene's role in leading public health core initiatives that focus on COVID-19 in community-based and primary care settings. And then tomorrow we will also begin at 1 p.m. as we did today. Please note that due to an unforeseen scheduling conflict, Denise Octavia Smith will not be able to provide the keynote. In her place, we are thrilled to welcome Ramana Rabbani, a current doctoral student in health policy and management at University of North Carolina at Chapel Hill, co-chair for the APHA CHW Section Policy Committee, and co-founder of the Community Healing Through Activism and Strategic Mobilization Organization, or CHASM. The third and final panel of our summit tomorrow afternoon will feature CHWs and researchers who will discuss their perspectives on what impact means for CHW programs and how it's defined, facilitators and barriers to impact, the role of trust, communication, and working conditions, as well as the different measurement methods and tools their projects utilize. We hope you will join us for as many of these panels as you can. The registration links are being shared in the chat box, as well as the speaker bios. And now I will pass it on to Jenna.
Thanks, Dina. Hi, everybody. I'm so pleased to be here. My name is Jenna Lupi. I'm the Public Health Core Program Director at New York City Health and Hospitals. And before I get started, I just want to thank Dina and Amy for organizing the summit and inviting our team to speak and for all their help along the way. Next slide, please. So this is a photo of our speakers today. I'm going to kick off just introducing everyone to the Public Health Core and what it is. And then I'm going to introduce each of our speakers, and they're each going to speak about their respective work and portfolios. Next slide. This is all of us again. So next slide, please. And next slide. Awesome, thank you. So the Public Health Core at New York City Health and Hospitals is a 250-person workforce of community health workers and supervisors, plus additional supporting staff. New York City Health and Hospitals is the largest public health system in the country. And we were really fortunate to start this work in June of 2021, starting to see our first patients in August. We have community health workers that operate in our ambulatory care settings, that should say 4 different care settings, apologies. We have CHWs in adult primary care. We have them in adult primary care clinics for patients with shared life experiences. We have CHWs in pediatrics primary care and in behavioral health outpatient. The intervention varies by setting, but all the interventions are grounded in patient-centered support for social determinant of health needs, clinical navigation, and connection to resources. This initiative is funded by the City of New York, and Public Health Core is actually inclusive of a community health worker program at Health and Hospitals, but it's also inclusive of a community-based community health worker program led by the city. And I believe there is another panel that's specifically focused on that initiative. For the rest of the presentation, when we refer to Public Health Corps, we're referring to the efforts here at Health and Hospitals. Next slide, please. So where do community health workers work at H&H? So we have CHWs in 4 of the 5 boroughs in the hospitals and health centers listed here. We have 11 acute care hospitals where our CHWs operate, as well as 6 federally qualified health centers that are part of our Gotham network. In order to receive CHW services at H&H through the Public Health Corps, patients have to be patients of Health and Hospitals. So we don't field referrals from the community. However, if a patient would like to become a patient, or I should say a New York resident wants to become a patient at one of our facilities where we have CHWs, then they would be eligible to be referred to the program. Next slide, please. 1 year in, we had some great results with our program. We had over 1,200 patients graduated from our 3-month adult primary care intervention. 2,100 patients were served by our BHCHWs, and over 200 patients were enrolled by our CHWs in clinics with shared life experiences, which we'll hear more about. Some common patient needs: food insecurity, financial insecurity, medical bills and gaps in health insurance, transportation, housing insecurity, and social supports and legal needs. This data was through the summer, so this past summer. So now as we are approaching winter, these numbers are much higher. So we've had really great success and been able to move forward pretty rapidly. Next slide, please. So this is one of our community health workers at Kings County Hospital with her patient. This is Juanita and her patient Neville. And this is what Juanita shared about her experience working with Neville. She said, "I got to know what he enjoys doing, what he's hoping for in the future, and what he thinks he needs my assistance for. That's most important. Our goal is to work on what the patient wants to address, because at the end of the day, we're looking to give them the motivation to better their health." So just really exciting to see the work that's coming out of the program. Next slide, please. So I'm going to talk just very briefly of the highlights about the adult primary care intervention, and then I'm going to pass it off to my colleague. So next slide. So briefly, the adult primary care CHW intervention focuses on the socioeconomic and behavioral barriers to health in low-income populations. It has a strong evidence base. We work with patients over a defined period of time to set health and personal goals and track those goals. We meet patients where they are in the clinic, the community, or the home. We are fully integrated into primary care clinical teams, and our CHWs serve up to 20 patients at a time for an intervention length of, on average, 3 months. Our CHWs also document directly in the electronic health record along with other care team members for continuity of care. Next slide, please. So I am going to pass it off to my colleague Janita Karn, who is the Primary Care Safety Net Project Manager. Just a little bit about Janita. She's a native New Yorker and has been working in social services for nearly a decade. In her current role as project manager, she supports the special population CHWs in our safety net and PERT clinics. These clinics provide wraparound services for individuals experiencing homelessness and individuals who are justice involved. So take it away, Janita.
Good afternoon, all, and thank you so much, Jenna. So as previously stated, my name is Janita Karn, and I am currently the project manager for the primary care safety net clinics, and I'm also the interim project manager for our port clinics. And we'll first have a brief overview of what the differences are between our safety net clinics and our port clinics, and then we're also going to discuss some key elements about what makes these clinics successful. If I could have the next slide, please. So our primary care safety net clinics are our clinics that are dedicated to servicing people experiencing homelessness with chronic medical conditions and who are socially complex. Our point of reentry and transition, colloquially known as our port clinics, are our clinics dedicated to serving people with chronic medical conditions who were recently released from jail or prison. We utilize our special population community health workers to provide the care coordination services, and they receive supplemental and specialized training in order to support this population. These trainings include, but are not limited to, webinars curated by Benefits Plus, the Health and Housing Consortium, and CUCS. We also provide our CHWs with shadowing opportunities at our existing sites and specific trainings on tools such as ePaces, Worker Connect, New York City and New York State inmate lookup, et cetera, et cetera. We are also fortunate that our Port CHWs are health workers who have lived experiences. So this affords them the opportunity to create unique connections with their patients. And another thing that is unique for our clinics, Jenna had previously stated that for the other CHWs, they are working with clients for 3 months. When a client is involved with Safety Net or Port, they are on caseload for however long they need us to be. Next slide. So what is complex care? Complex care seeks to improve the health and well-being of a relatively small heterogeneous group of individuals who repeatedly cycle through multiple healthcare, social service, and other systems, but do not derive lasting benefits from these interactions. Complex care seeks to be patient-centered, so individuals' goals and preferences guide all aspects of care. Equitable, addresses systemic issues such as poverty and racism. Cross-sector, breaking down silos and encouraging collaboration to create change. Team-based, interprofessional, non-traditional, and inclusive teams. And data-driven, closely cross-sector data to effectively meet needs and evaluate success. Next slide, please. So what does complex care look like for the homeless and justice involved population? These special populations have lacked access to social, political, and economic power due to institutionalized and societal discrimination, such as systemic marginalization, hinders access to healthcare, which consequently exacerbates negative physical and mental health outcomes. Also addressing the needs of these populations requires intensive primary care, dedicated care coordination, and collaboration with community-based organizations. Next slide. So some of the key elements that have made these clinics successful. So intra and interdisciplinary team-based care. So internally, this looks like pre-clinic huddles, after clinic follow-ups, bi-monthly roster reviews and case conferences. Externally, this looks like case conferences with external care teams. Sometimes the patient is present as needed, consistent follow-ups, and care either via phone, email, field visits, however we can get in touch with the patient and their external care team. Behavioral and addiction services via physicians who are bupe waivered or can give naloxone injections or Hep C treatment. Patient-centered care planning, working on goals in an order that is the most comfortable for the patient. Intensive in-person outreach and referral engagement with the client, referral source, and emergency contacts, which includes field visits to medical and social appointments, visits to shelter, safe havens, or where this patient may be bedded down. Connections to local community-based organizations, including street outreach and familiarity with shelter and housing resources for patients. So we have intensive collaborations with these systems and a working knowledge of processes, which allows the on-the-ground and admin staff to guide patients through extensive hospital and social service systems and breaking down silos bit by bit. Collaboration with internal specialists. This helps promote health literacy, addressing barriers to appointment and medication adherence, and providing advocacy as needed. dedicated clinic space and staff. We're creating a safe space for our patients, and unfortunately, safe spaces are often luxury for this population. Also increasing adherence to medical appointments and decreasing non-emergent visits to the emergency department, as patients know where and when to find clinic staff and can receive assistance from anybody on our team. Flexible scheduling, so a very low barrier to scheduling limitations. Unlike many clinics, safety net and port patients can be rescheduled for as many times as needed and can be seen by their provider on non-clinic days or times if required. We even have more flexibility when scheduling and rescheduling with the care coordination staff. And all of this is not to say that we don't have any setbacks. We still have to deal with red tape and silos and high staff turnovers, which are unfortunately woven into our healthcare and social service systems. But as fierce advocates, our special pop CHWs are utilizing their training and their hand-on experience to provide patients with appropriate level of care and treatment, regardless of their housing status, justice involvement, behavioral health status, and immigration status. Jenna, do I have a few more minutes? I see you popped up. Okay, so I just want to speak really quickly as a project manager who also has extensive care coordination experience. I am charged with providing support to our clinical staff. This includes, but is not limited to, standardizing our onboarding process, creation and dissemination of supplemental program manuals, workflow improvements, fostering and reevaluating partnerships with community-based organizations, being solution-oriented. And I think most importantly is being a listening ear and also promoting boundaries and self-care with our staff, because this is very selfless work. Next slide. And this is Denise. She is actually a CHW that I work with directly at our Lincoln Safety Net Clinic. So a quote that she had stated was, as a community health worker at Lincoln Hospital, I get motivated every day that I am able to connect with people with the best healthcare and the best team so they can be helped in a way that they deserve.
Thanks so much, Janita. Thanks, Janita. So now I'd like to introduce, lost my place. I'd like to introduce Natasha McIntosh White. Natasha entered public health court as a CHW for special populations with the Safety Net Clinic. She was recently promoted to the adult medicine CHW supervisor. And Natasha has worked with the underserved population for over 15 years. So Natasha, take it away.
Hi, thank you, Jenna. Really excited to be here talking to you guys about my experience with the Safety Net Clinic and now being a supervisor for adult primary. So we can get started. Next slide, please, Jenna. So just a little bit of background information on the patient that I chose to speak about today. Still have a really good friendly rapport with this patient. They came to New York during the pandemic, which a lot of New Yorkers, I think everyone in America was still trying to figure things out where their life was gonna go. He was actually homeless before the pandemic, and during the pandemic, he found himself in the New York City shelter system. And that's kind of how HHC became aware of him. He actually had an overdose while he was in the shelter, just kind of recovering from the life that he lived. And he was referred to Safety Net from there. He was 56 at the time, suffering from osteoarthritis, chronic knee pain, pre-diabetic, kind of like a slew of ailments that he hasn't had addressed in years because he didn't have primary care, or any access to primary care, we should say. So we enrolled him into the program November of 2021. And his goals were to end homelessness. And as Juanita was saying before, being a part of Safety Net, that's not a 3-month process. So we get the chance to actually keep these patients on our caseload for as long as we need to work with them to kind of bridge them provide them the access to the resources that they need. I like to consider CHWs as like a bridge connecting social resources and healthcare, because the people in our community, they may know what they need, but they may not know what resources are available to them or how to access it. And I think that's what we do such a great job at doing, you know, because a person is not going to be able to think about their next doctor's appointment, or at least the population that we work with is not able to think about their next doctor's appointment if they don't know where they're going to sleep at night. You know, if they don't know how they're going to feed their children, if they don't know where their next income source is coming from, basic needs are always going to be precedent. So the patient's goals continue to be kind of ending homelessness. One thing he really had a difficult time doing was remembering his appointments, figuring out how to get to the doctor. And my chart is just perfect for everyday medical life, when you need to communicate with your doctor, when you need to ask a question, reading your labs, getting some information on understanding your labs. He also needed assistance with receiving some sort of income, wondering if he qualified for like SSDI or SSI, HRA benefits, public assistance, SNAP, all of those things. Once again, understanding the resources that's available to him, assisting him to apply, and if he does qualify, continuing out that process. This patient also had no social security card, no ID, and transportation back and forth to the doctor was even an issue, especially with the chronic knee pain. Next slide, please, Jenna. So the accomplishments, or what we worked on, the goals that we worked on with this patient, we taught the patient how to access and use my chart so that they can remember those appointments. Gaining primary care for this patient was kind of the best thing for them, because along with the hypertension and the diabetes that was kind of, you know, becoming more issues for them, they didn't have any access to primary care for years before that other than the ER. So this not only allowed them to be connected to their primary care physician, it reduced the ER visits that the person had before. We assisted them with completing their social security card, applied for SNAP benefits, followed the patient, or accompanied the patient, I should say, to these locations, whether it was social security, whether it was the HRA, to sign up for the benefits. We assisted the patient with Section 8 emergency housing voucher, and this patient was able to receive an apartment in a supportive housing building with his HRA housing voucher. So to go from homelessness to receiving their own permanent housing was just more than awesome, I could say. Clarifying his disability benefits, understanding what benefits he could apply for, and SSD was one of them, which he did qualify for. Rectifying his HRA benefits, helping him to get a New York State ID, helping him to understand his medical insurance, and he definitely received a walk-in cane. And I can say from speaking with his primary care physician and just keeping in contact with him, he no longer suffers from chronic knee pain. He does still have the osteoarthritis, but the pain is not as chronic as before. Next slide, please, Jenna. So just to go over some of like the day-to-day with working in safety net, just to revert back to what Juanita was saying before, is very comprehensive, very complex, very patient-centered care. And I think the best part of that is the huddles that we do in the morning, because being a CHW, we are actually part of the care team. That means we speak with the case managers, we speak with their primary care physicians, we speak with the RNs, we speak with the PCAs. When they have information about the patients, they call us as well, because we play an essential role in the patient's overall healthcare. So attending huddles has always been a great thing. Checking the calendar just to make sure I understand what interviews I have coming up, or meetings or conferences. Everything is just kind of surrounding the patients and their day-to-day health. Weekly calls and follow-ups for the caseload. They were mentioning before, we have about 20 to 25 people on each CHW's caseload. So reaching out to those patients on a weekly basis, following up with them, providing those reminder calls, assisting them to set up transportation, and really conducting meaningful outreach, like informing the patients of what the community health worker program is like, what it can offer them, hearing what they could benefit from the program, what goals they have, reminding ourselves how person-centered care is processed, and just kind of assisting them with obtaining a quality of life to their standards. Again, us being that bridge crossing over from social determinants to, positive healthcare, a person has to be able to manage their basic needs and set their quality of life in order to focus on their medical care. So I think that's what us as CHWs help our population to do. And next slide, Jenna, thank you. And just my role as now that I've been promoted, thank you again, with primary care, the adult day-to-day, it is less hands-on with patients, which I do miss, but it is increased communication with the care teams, with the doctors, with the case managers, and I really get to support my team of community health workers now, with accessing those resources, providing moral support, discussing those challenging cases that we really can't find any resources for, or just legal determinations in any way that I can, just continue to building the team of community health workers we have and providing that high quality, complex care to the patients and the people that we support in our community. That's all I have. Thank you.
Thanks so much, Natasha. It's amazing to hear of all the great work that you've been able to do with patients, and congratulations again on your promotion.
Thank you.
Yeah. So next I'd like to introduce Shantae Henry. Shantae is our public health pediatrics CHW program lead. And Shantae actually worked as our star ped CHW during the pilot 321 impact program, which we'll talk about, before she stepped into the role as program lead. And she's also a certified lactation counselor and a Lamaze certified childbirth educator. So Shantae.
Hi, good afternoon, everyone. Thank you, Jenna. Next slide, please. So the PEDS primary care CHW model is an expansion of the CHW component of the 321 impact program that's currently being piloted at Gouverneur, Bellevue, and Queens Hospital. This pilot started back in 2020, basically at the beginning of the pandemic. And so there were lots of lessons learned. I was the sole CHW at Gouverneur at the time. And so a lot of the experience that I gained from that time was able to inform a lot of the work that we have done to create this program and provide the kinds of support that CHWs need in order to support families. The impact model integrates 3 disciplines: women's health, pediatrics, and behavioral health, to provide a 2-generational approach to care that includes the child and their caregivers. The goal of the program is to support the health and well-being of young children and their families, understanding that the well-being of the family as a whole has a great impact on that of the child. Next slide. Eligibility criteria for the PEDS CHW program includes children 0 to 5, as well as prenatal patients. Any insurance, including the uninsured, non-acute, non-complex psychosocial, socioeconomic, or medical needs. And the CHW intervention is meant to support families for 3 to 6 months, although depending on the family's needs, they may be supported by a CHW for shorter or longer periods. And after completing the support with a CHW after a few months and they're graduated, they may re-engage with a CHW at any point if new needs arise. The most common referrals to CHWs are for early care and education. So lots of referrals for developmental delays and services, special education, early intervention, also connection to daycare, childcare, parenting support, which includes home visiting programs, programs like Power of 2, social determinants of health, including anything from food insecurity, housing insecurity, insurance gaps, financial assistance, connection to WIC, and maternal child well-being with a focus on postpartum care continuity. And so CHWs would be helping to ensure that new parents are attending postpartum visits, are helping to schedule visits if there aren't any scheduled as yet, and also working with other team members to refer out to dyadic counseling if needed, and connecting to primary care for new mothers. So those who go through a pregnancy and have medical care may not have that continuity of medical care, don't have a primary care provider once they've in that postpartum period. So CHWs play a role in helping to connect those parents to primary care. Next slide. The general workflow for PED CHWs includes preparation, where the CHWs review referrals, visit notes, and any SDOH screenings to understand the patient's clinical care plan. They outreach to the family either in person during the clinic visit or over the phone to discuss the family's needs and collaboratively develop a plan for addressing those needs. The CHW then makes appropriate referrals to connect families to resources and help navigate those referrals, and then finally close the loop on the referrals with the families and also the referring providers. Next slide. Currently, pediatric primary care CHWs are located at 11 acute sites and five community clinics, and we have 50 PED CHWs and CHW supervisors across the 16 sites. Some of the CHW supports that we provide on a regular basis are weekly Q&A sessions where all CHWs and supervisors across the 16 sites can bring questions, such as finding resources for a particular need, discuss challenging cases, and where program updates are shared and discussed in detail. Monthly site-based check-ins where supervisors have dedicated one-to-one coaching time around site-specific questions and needs. Monthly grand rounds where these monthly meetings are open to CHWs, the PED CHWs, but also to other pediatric care team members, and monthly case conferences that sites will hold where CHWs can present cases and receive feedback from other CHW pairs. Next slide. Here, we have a quote from one of our CHWs at Queen's Hospital. Kieran says, "When I talk to my patients, I can see how their personal issues are linked to their health. Helping these patients get on the road to feeling better so that they can get back to doing the things they enjoy most is such a rewarding part of my work." Thank you.
Thanks, Shantae. I didn't even have to come on before to okay. Thanks so much for walking us through the PEDS overview. So now I would like to introduce Yamalise Salsi. Yamalise works at Langone Hospital as a community health worker. She had the pleasure of working with World Trade Center survivors by scheduling their long-awaited initial visits at the call center, as well as supporting and educating patients who called the COVID hotline at health and hospitals. Her desire to help others began when she was a child and has continued to grow over the years. So welcome, Yamalise. I'll hand it off to you.
Good afternoon, everyone. It is a pleasure to be here representing Langone Hospital and also our PEDS CHW program. Today, I will be talking about one of my clients. It was a very complex case due to the fact that there were many things that we couldn't help with, but at the end of the day, I did my best to help them. Next slide, please. So my patient is a 6-year-old child who moved to the United States with her family from Honduras in search of a better life. My patient has cerebral palsy as well as other medical conditions that limit her quality of life. The family lives in a shelter, and the mother at the time did not believe she was being supported. The child was getting sick more often due to the conditions in the shelter, and she was moved to a different unit due to less exposure. The patient goals that we were working to achieve was CPSE for the child to receive the education that better fits her needs, immigration services, food insecurity, and diapers. Next slide, please. So while we are shipped together, I work closely with the child's provider to get documentation ready prior to the CPSE evaluation. The child was evaluated and it was determined that she needs occupational, physical, and speech therapy. There were some delays, but the child is scheduled to start school this month. I took the parent to see a food navigator at Langone Hospital to apply for SNAPs. Unfortunately, the family did not qualify. I did provide a list of food pantries where the mother continues to get food. I provided multiple immigration resources. I worked closely with the social worker. We were unable to really help in that matter because the mother wasn't able to obtain some of the necessary documents that she needed. Another thing that we did was I was able to connect them with Bundles of Joy as well as Little Essentials, where she received donated items and diapers. Due to the child's condition, the child needed transportation to get to appointments. The biggest issue was that the child did not have Medicaid and we were unable to enroll her. The mother had mentioned that during the summer, this child was crying a lot because it was too hot. So I proceeded to talk to the primary care provider and we got a letter detailing the child's medical conditions so they could get a new air conditioner, and it was successful. She actually got a new unit installed in their apartment. I also advocated for the parent to receive a wheelchair for the child. There was a supply chain issue, and in the meantime, I reached out to multiple organizations that were more than happy to help. However, the developmental specialist stated that it will be best to wait for the one that was already requested because it was a custom-made one, so that will make more sense. Fortunately, the issue was resolved and the child received a wheelchair. My patient, there was a little issue where they were missing a lot of appointments, which in a sense I understand because they do live in Brooklyn and we are located in the Bronx. But after talking to her a little bit more about why it was important due to the child's condition, there was a significant improvement afterwards. Next slide, please. Okay, so my typical day as a CHW at Langone, it consists of multiple calls throughout the day. It could be either patient outreach, follow-ups, or communicating with various providers through Epic Secure Chat. I also contact various organizations to ensure that they provide specific services for our clients. And I maintain constant communication with school districts when I have CPSE cases. I help families schedule appointments for their children and remind them of upcoming appointments. I advocate for our children to ensure they receive the assistance that they need. I meet with parents to help them fill out some forms and review important letters. I ensure that the parents gather all the necessary documents when they apply for services and follow up on the status of their application. Next slide, please. So my favorite aspect of my job is seeing and hearing my patients' joy when they receive the assistance they need, and knowing that I was able to make a difference. I was able to assist someone who had been let down by the system over and over. The most difficult aspect of my job is not being able to help some of my clients when they do not qualify for certain services, even when they desperately need them. To me, it's heartbreaking, but indeed not discouraging. I always tell them to keep fighting and never give up. And another challenge we face as a group is that some parents fail to engage or follow up on the resources provided. We make the first phone call, we do the interview, we review the services that they may need. but later on down the line, they might start not answering the phone or not showing up to the appointments and things like that. We do our best to help them navigate the system and become more self-sufficient before they graduate, but it's not always easy. Even so, we strive for them so that they can have that extra support when needed. And I just wanted to tell you a very short story. This was a case that I literally graduated right away. The client stated that they had mice in their shoulder unit. So as soon as I got off the phone with her, I just made a call to 311. I put her on the phone as well. We made the complaint. Within 24 to 48 hours, they showed up. It was determined that they also had lead paint in the shelter. In the unit. And everything was resolved. The following week when I called her, she told me, hey, they just moved me, they transferred me to another shelter. It's much better. It's in Manhattan. And she was so happy. So like, sometimes we get like very difficult cases, but there are others that are very, very easy. So I was very happy to help. Next slide, please. Oh, thank you.
Thanks so much, Annalise, and thanks for that additional story, which is amazing to hear. So last but not least, I want to introduce Evelyn Perdomo, who is our Public Health Corps CHW Coach Program Manager. Evelyn joined Health and Hospitals as a CHW supervisor in 2019, where she assisted in launching a pilot CHW program at Queens and Elmhurst hospitals that preceded Public Health Corps. She currently leads a team of skilled CHW coaches who provide on-site training and coaching to the CHWs throughout each facilities. So Evelyn, take it away.
Awesome. Thank you so much, Jenna. Next slide, please. Okay, guys. So today I'm going to just be talking to you about some of the training and support that the CHWs receive. So when the CHWs are hired, all the CHWs, regardless of, where they're situated, whether it's special pops or peds, adult primary care, they all participate in a 2-week intensive training. It's the impact training, which is conducted by the University of Pennsylvania's Center for Community Health Workers. And that training consists of the CHW core competencies. It also covers motivational interviewing skills, CHW code of ethics. So just giving you some examples of what that 2-week training entails. And they also receive training on EPIC, which is our electronic health medical record system. So they get that training where they get access to EPIC. And they also sit in a training NowPow, which also is our resources database. So the CHWs use NowPow to look for community resources, and it's embedded in EPIC. Next slide. So the CHWs also receive supplemental training. So pediatrics and special pops, CHWs will receive specific training for their program areas. So, for peds, it could be something like early intervention trainings. And for special pops, they work more with a special population. So a lot of homelessness trainings. So that's based on their program areas. And then we provide monthly training series. When I say we, our Office of Population Health, we provide monthly training series, which covers a multitude of topics. Some of the topics I've listed here are, benefits and entitlements, Medicaid, Medicare, communication skills, financial empowerment for both the CHWs and the patients, mental health trainings, mandated reporter guidance, APS and CPS reporting, and then again, we reinforce EPIC and NowPow. Next slide. So where I come in mostly is providing coaching. So as Jenna mentioned, I lead a team of coaches. Our coaches originally started as community health workers, and with the launch of the Public Health Corps, they transitioned to become special operations coaches. So we have a total of 6 coaches, and they provide support to all of the CHWs, adult primary care mainly, and and special pops. The pediatric CHWs do receive monthly site-based coaching, and Shantae is our lead for that department. Coaching is provided in person or virtually. So we really cover a lot of the topics that they already participated in during the Penn training. So, everything that they covered during Penn, but we provide our best practices. As when we were a CHWs and they're new coming in, we provide best practices on an effective outreach strategies, assessing and addressing patient needs, home and community visits, best practices, documenting an EPIC, resource identification and navigation, communication skills, CHW skills. And a lot of these coaching, again, it's reinforcement. So it's a lot of like support on site, individual support. It could be in a group setting. It could be during their case conferences. So, that's the role of the coaches. And we have a total of 6, as I mentioned. Next slide. And then I also provide coaching for our supervisors, adult primary care supervisors and special pops. So I meet with them to conduct a small training, basically to go over their role as a supervisor based on my experience supervising my team when we first launched in Queens and Elmhurst. So the training and coaching that I provide focuses on some areas where it's managing the CHW program. I go over like referrals, managing caseloads and enrollments, and pulling reports from EPIC, managing their team, best practices when conducting one-on-ones, establishing their case conferences, identifying topics that they may want to cover with their team during case conferences, and also helpful resources and tools such as resources navigation, development of community and facility-based resources lists, which will include the financial counselors that are at their sites, or WIC offices, or food navigators. All of these resources that are specific to their facilities that their CHWs should know about. So when they need to connect their patients to these resources, they have easy access to them. Next slide. This is the team of coaches. This is my team, 6 of them. And, they're all amazing at what they do. So just wanted to show a picture of them. Next slide. And that's all.
Thanks, Evelyn. All right. So thanks to my team, everyone, for presenting from your various perspectives. If everyone could turn their cameras back on, we're going to go through some questions now that we're fielding from all of you out there. So my first question I'm going to actually direct to Shantae. So Shantae, the question is, do peds CHWs sometimes use a family approach when working with children? And is that more time intensive, or does it require more resources than working with adults?
Yes, so CHWs do have a family approach. Sometimes the needs that the patient is referred for are specific to the child. So for example, evaluations for developmental delays, but there's often family needs that go along with that, like the need for connection to food resources or housing resources. And so it can become quite complex. So, the referral might have one particular need listed, and then the CHW speaks with the family and there's an additional 5 needs. And it can be quite overwhelming for a family to address all of those needs at the same time. And so the approach really is to prioritize what those needs are based on what the family decides are those priorities. I wouldn't say it's more complex than the adult model. I think that both are quite complex, and it really depends on that particular patient's needs.
Thanks, Shantae. All right. Next question is for Natasha. So Natasha, can you speak a little bit about what kind of additional training is helpful or required for CHWs to work in special populations like safety net?
So I think generally impact training is what we go through as community health workers. But for safety net, we get additional trainings that kind of benefit our population, like trainings for Workers Connect, which we can use to help identify patients in the shelter system and connect it to HRA. We go do like Medicaid trainings, Medicare trainings, anything on benefits. We also do a lot of trainings on like legal services to kind of help our undocumented population, which we have a lot of. A lot of the benefits and resources that are available to our other patients aren't really available to them. So there's trainings on how to serve them more. So I would say more resource-based training outside of impact and EPIC, which we get from the hospital.
Great. Thanks so much, Natasha. And staying on the safety net thread, my next question is for Janita. So Janita, could you talk a little about some of the challenges or successes of integrating CHWs into the safety net clinic teams? And also, as a sort of add-on question there, did the safety net physicians already have experience working with CHWs prior to public health core, or was that new for them?
So thank you for the question, Jenna. I'm gonna answer the question backwards. So this is the first time that the safety net clinics were working with CHWs in this capacity. However, safety net clinic had always worked with care coordination staff. I was actually one of those care coordinators in my previous role, and we had always been embedded in the clinic, and we were just coming from a different department within our hospital system. I think some of the challenges that we've had experienced, mostly a lot of the challenges are around space. Our clinic staff grew rapidly, even from CHWs and also physicians. So we've been running out of space for quite some time. We're still running out of space, and we're still making it work the best that we can so that we can make sure that the patients are getting all of the services that they deserve. And I think so we're dealing more with a lot of successes and that's what I want to highlight. So I think for us, we're having a lot of successes as a team because we work very closely, even from the admin staff. So I sit in our central office now, but I do visit the facilities. So I think really working very close together from the beginning and making sure that our CHWs were looped in and they always felt like they were part of the work family, made sure that we were providing services for the clients the best way that we can and the same level of services. And one of the other successes with having the CHWs come on, and since there was more staff, we were just able to provide more care coordination services to more people on the patient population in those clinics.
Thanks so much, Janita. My next question is for Yamalis. So Yamalis, given your experience in your role, what have you found are the most important skills for CHWs to have when they're working with patients?
I believe you need to be very resilient. It's not always an easy thing to work with the patients because there are many things that that you cannot do. Not because you're not allowed to, it's because it's not possible. I feel you really need to have that need, that want to help the community for you to be a CHW. That's very, very important. If you're not in to help people, then it's not the job for you.
Thanks, Yamalis. Yeah, I appreciate your point about there are often things that we literally can't do. And that can be a really hard thing to accept, especially if you do want to help people, which our CHWs, Yamalis, Natasha, and others very much want to. So that's a really hard part of it. Okay, my next question, no surprises for Evelyn, since I'm going around. So Evelyn, let's see, which one do I want to go with? Can you talk a little bit about CHW's experience coming into the role? Do they tend to have training or previous experience with CHWs?
Sure. So our CHWs, they come from different backgrounds. they don't have to have any specific, I guess, like certification to become a CHW. We do want them to have some type of experience working in the communities, working with people in the community. Most of our CHW's experience range from serving as either case managers in the past, or even being from the community they serve, speaking the same language as the patients that they'll be working with. And many also come from volunteer programs, freshly graduated from a CHW training program. So there aren't, there's not like a specific training program that they need to complete, but we do want to make sure that, like Jamily says, that you want to take, if you're going to enroll, apply for this type of position, you have to understand that, you want to be able to work with patients, you want to have empathy, you want to be able to support them. You're not coming into this role for money. You're really coming into this role because you have lived experiences, or you want to support the people in your community. So I would say that anybody can be a CHW as long as you have the passion and the commitment to do so.
Thanks, Evelyn. Okay, I have some questions here that I think any of you could answer. So I'm gonna pose it to the group, and whoever wants to jump in, feel free. If no one jumps in, then I'm gonna have to, call one of you out. So the question is, what role do CHWs have in supporting patients with mental health and behavioral health needs? And also, what training do CHWs receive on providing that kind of support?
I can jump in and say that, as a CHW, we're not specialized. We don't have a specialty to work with a specific mental health diagnoses. For any patient that has any type of diagnosis, we always work in collaboration with the providers. We work with our supervisors. We focus on the patient's goals. If the patient's goal, even if they have anxiety and depression and their goal is to work on food, that's the focus of our intervention. We're not focusing on the anxiety or depression unless that's what the patient wants to work on. And then we work in collaboration with their provider to come up with a plan, to make sure they have the meds, that they're coming to their appointments. That's the extent to how CHW would work with a patient with any type of mental health diagnosis.
Thanks, Evelyn. Does anyone else want to add on, or shall I move to the next question? No? Okay. The next question, this is for Natasha and Yamalis. So maybe Natasha, if you want to go first. So the question is there any experience that you've had that has really helped you in your role as a community health worker?
As mentioned in my bio, I feel like I've been working with the underserved population for majority of my career for the past 12 to 15 years. So that alone, I feel like kind of makes me more aware of the population that we're working in safety net. And other than patients, I refer to them as my neighbors, because like Evelyn was saying, it's not only professional work or educational work, is really knowing the people, where they come from and the struggles that they're dealing with, and how to just kind of provide the resources that they need. What makes us sometimes, good CHWs. Trainings are always gonna be beneficial. On-hand work is always going to be beneficial, but when you kind of get down to the basis of why something simple as maybe they're missing their appointment, maybe they don't have a telephone in the house, so kind of just meeting the patient where they are and walking with them to where they need to be rather than kind of expecting them to get there. Those skills I rely on the most, more than my professional and educational background, if that makes sense.
Yes, when I first learned about this job and before I left my previous position, I was very excited because I knew I was going to help families, especially women and their children. I've been there before. I come from the Dominican Republic. I've been here since 2009. When I first got here, although I came as a resident, I did not know how to navigate the system. Then I had a child and I wasn't working. I was going to school. I was doing this, I was doing that. And I had to get welfare. And I have no shame on saying it. I had to go through all these little things that a lot of my clients are going through. So to me, that really helps me and gives me the motivation to help them even more, because I know how hard it is when you don't have someone there that can help you and guide you the right way to get the things that you need for you and your child.
Thanks so much, Natasha, and thanks so much, Yamalis, for sharing your experience. And I think it's fair to say that many of our CHWs have a similar story, have an experience that really informs the work that they do with patients. And just wanted to say how much we all appreciate that after you've gone through that experience, that you want to help others going through it as well. So thank you both for sharing. My next question, I lost it. Okay, here it is. Okay, so this one's going to be for Shantae and Janita. So Shantae, if you want to start. So the question is, first, it's a statement. Workforce is a significant issue lately. So two-part question. How do you advertise and get, staffing? And then also, how do you maintain the staffing you have, and what's important in keeping the staff that you have?
So in terms of advertising, the job postings are on the H&H Careers website. And so the general public can search and apply for CHW positions. And then in terms of maintaining the workforce, it can be quite challenging, especially when the work is challenging and the program is new. We're kind of flying the plane and building it at the same time. And I think that requires tons of support to the staff, being super available when there's questions, when a site, a supervisor, a CHW reaches out and has a question, and just being available to answer those questions. And if you're not sure of the answer, making sure that you find someone who can answer those questions. And I think also having opportunities for building skills, knowledge, and career development is also important. I think if a CHW feels like they're going to be in that same position doing the same work for 5-7 years without the opportunity to grow, they're going to be less likely to stick around.
As far as advertising, as Shantae said, Health and Hospitals does have a career page. One thing that is newly launched for Safety Net and Port is we do have our own specialized career page. And I want to thank my colleague Monica, who is in the chat, and she put the link in. If she doesn't mind dropping the link again. So that is another way that we can use advertisement efforts. I know personally, I am involved with different career groups. So I reach out to my personal networks to also field for open positions. As far as retention, I think starting off with choosing people who really want to do the work helps. Because even when it gets tough and it's the 9th hour and it seems like you're trying to make the impossible possible, if you're somebody who's truly here to do the work, you'll stay for a bit. And I think also really creating a team that feels like family. I know, like, we're taught, like, leave work at work, and people that you work with are not family, but you spend a majority of your life at work. And being able to trust each other on some level, I think really helps with helping with staff retention. And then there also will have to be a point where, as Shantae stated, where there has to be some promotion opportunities and actually helping someone get to that next level.
Absolutely. Yeah. Thank you both. I just really want to echo that last point. I think it's super important to be creating a pipeline as much as possible in the healthcare system. And we're, to Shanti's comment about flying the plane while you're building it, I think we're still very much doing that but that is a piece that that we have our eye on. So, okay, my next question I'm going to direct it to Evelyn, but once Evelyn responds, anyone else feel free to chime in because I know this is a little different by setting. So the question is pretty simple. It's, do the community health workers conduct home visits?
Oh, sorry, I was on mute. Yeah, so the community health workers do conduct home visits. They conduct it in pairs usually. We implement a buddy system, and they, conduct community visits as well. They meet patients, at the, food pantries, at the SSI offices, at the homes, in the park next to the home, in the hospital, in the clinics. So they're actively meeting with patients. They meet them what they are.
I would say for safety net, because majority of the patients are shelter residents and dealing with the pandemic and privacy issues, they weren't really allowing people to come in, case manager, community health worker or not, wasn't allowing us to come into the shelter. So what we did on the safety net side is just pick days when we'll visit one shelter that had multiple of our patients in there and kind of met them outside, or like Evelyn was saying, in the community, to still give them that full feeling, of the entire program, having someone meet you in your environment, in your element outside of the hospital. So
For pediatrics, CHWs can do home visits, but it's not something that is a regular part of their workflows. It would be most appropriate in a situation where a parent is unable to leave the home for a specific reason and documents need to be signed, for example, or there's a really specific need for that, but it's not a standard part of the support that CHWs are doing on the ped side. That being said, the younger population tends to come into clinic more often, not just for sick visits, but just for well visits. And so there are a lot of opportunities where the CHWs are able to see families face to face.
I think one thing I'll just add for Safety Net Port, we have been working really hard on housing initiatives. So we've been able to get a lot of our clients into permanent housing. And one of the things that we're going to be implementing in our workflow is for the CHWs to visit the client when they first move in and just making sure that they are acclimating to their new space.
Great, thanks everybody. Hot topic, home visits always. Let's see, next question. Okay, I'm gonna kick off the answer to this question and then feel free others to jump in and add on. So the question is, how can we ensure that CHWs are being optimally used for services they can provide? There's an additional part of the question, are there issues of credentialing and medical hierarchy getting in the way of this? So what I wanted to just say before I open it up to the rest is, this was a big concern when we launched the program. And there's some history of community health workers and other similar roles that get pulled away from the work that they're supposed to be doing. Particularly when you're in a hospital setting where we're always short-staffed. And so this is something we're always, I would say, on high alert for. From day one, we've been very explicit about job descriptions, about ensuring that everyone has the appropriate training, that our coaching team is there and monitoring what the work that is being done, that we're checking what's going on in the charts. We meet regularly, as in every month, with the program team at each facility, at each hospital or community health center, to review what's happening. We monitor monthly metrics. That's for all care settings represented here. So we are very close to the work to ensure that that's not happening. And what I will finish with is, I think at the beginning, there were some attempts to get sort of pull our workforce away and into other things. And I feel like that has diminished over time. And I think that's because we, the people here and others, have made it very clear that that is not what our community health workers are here for. They are here to do a very specific role, just like any other provider in the system. So that's what I'll say. Does anyone want to add on to that?
Yeah, I will say that at this point, it's almost the opposite, where CHWs are being pulled in for things that may actually be outside of their scope. And that's just because there's a limited staff. Everyone is spread thin. And so, if social work is spread thin and a family needs that level of support, because the CHW has been so incredibly helpful in so many ways, the provider is likely to say, who is the most helpful person that I can pull in right now? And because CHWs are so easily accessible, they can be pulled into situations where it may not be appropriate for them to be on the lead on that case. And so we've also done a lot of work around creating a really clear scope of practice for the CHWs, and also guiding them in how to communicate with providers around letting them know that a particular case is not within their scope, and the appropriate means for referring that family to the right person.
Awesome. Thanks, Shantae. That's a really good point. Yeah, that's like, we started in a different place and now it's everyone wants community health workers to do everything because they're so good at what they do. Okay, let's see what else. Okay, so I can address this one. I think this one's pretty straightforward. So the question is, I work for a CBO that largely serves the Latino community in Brooklyn. How can I go about setting up an event that promotes CHWs, or do they need to be referred? So yes, so patients, I should say New Yorkers, need to be patients at one of our health and hospitals facilities with community health workers in order to receive community health worker services. So if you know a resident, or in your work you interact with a lot of folks that could benefit, my recommendation is for them to call the call center to schedule an appointment with an H&H provider, and then subsequently that provider can refer. And let me just back up. That is specific to adult primary care and to pediatrics. Janita, do you want to speak at all to how things work with safety net and port?
I'm sorry, can you run the question back for me, please?
Yeah, sure. I mean, the ultimate answer here. So the question is about referring patients in the community to work with a community health worker if they're not an H&H patient. And the pathway for primary care and peds is fairly straightforward in that they need to, call the call center, make an appointment, and have a provider. I know it's a little bit different in safety net and port if you want to talk through that.
Yeah, so due to safety net and port, we have a lot of collaborations with community-based organizations. So we'll get direct referrals from those CBOs. So I know for safety net, the proper workflow is that there's a referral email for each of our clinics. They should be sending an email and listing all of the demographic information for the client, as much information as they can give us, and we would reach back out to them with the next available appointment. Sometimes we'll end up taking referrals via phone call. Sometimes we have flyers for safety net clinics and for port clinics. So we also may have clients that walk in, so they need to be triaged by the nurse to assess if they're appropriate for the clinic. And then we can see when we can get them on the schedule. So it's a little, we don't use a call center at all. So it's a little more hands-on our referral process.
Thanks, Janita. Let's see, we have a few more minutes. I have a question for Yamalis. Have you, and if so, how have you navigated some of the more difficult conversations with parents about vaccinating children, specifically for COVID-19?
Well, at our site, I don't think we have had that happen. From what I've seen on my clients' charts, a lot of them don't have the vaccine. And it's just something that doesn't come up into the conversations. There are ones that they ask about it, and I'm more than happy to give them the information because I was a contact tracer. I know the importance, but it's not something that is talked about all the time.
Thanks, Yamalis. I don't know, Natasha, that question was more about peds, but I'm curious if that comes up at all in the adult population.
it's definitely a question that we ask if they're vaccinated, and if they're not, we ask them if they would like to. Here at Woodhall, we have a COVID clinic that's open 7 days a week throughout. So we even walked a few patients over there to get the vaccine, kind of support them while they're doing the process, remind them of their follow-up vaccines, whatever it takes. If it's something that they don't want to do, we're not here to push. Remember, this is person-centered, it's their goals, it's their life, the quality that they want to live. So if it's no for them, it's no for us. We're not the medical providers here.
Absolutely. Thanks, Natasha. Let's see. We have 2 more minutes. Ooh, a lot of home visit questions. People are very curious about home visits. I'll take this one just briefly. So the question is, just to clarify that CHWs are doing home visits due to the patient, not because it's a part of the role automatically. So that differs by care setting. So in adult primary care, it is a part of the intervention, and CHWs do offer home visits to every patient. Of course, many reasons why patients may not want to do that home visit. That was even more the case a year ago, obviously, with COVID, and we're still learning a lot about how to get back to regular home visits in sort of the post-COVID era. It's a high focus for us right now. Prior to Public Health Corps and prior to COVID, our pilot CHW program, we did home visits for almost every patient, and that was very standard. So in the post-COVID world, it has changed a bit. For pediatrics and for safety net and import, it is much more patient specific. It is not required in the way that it is in the adult primary care setting. And I see Amy, so I will pass it over to her.
Wow, thank you so much to this entire panel. It's been so moving and so gratifying to hear about the incredible work that you're doing. I mean, what a, and I'm sorry for the background noise, what just a massive initiative and undertaking that you've pulled off in such a short period of time. When I saw your first slide, Jenna, that you've hired over 250 people, CHWs and supervisors, like that's really amazing, and that you're in over 20 hospitals. Sorry, I didn't introduce myself. I just popped down. My name's Amy Freeman. I am one of the faculty leads in the Department of Population Health, running the Community Health Worker Research and Resource Center. And yeah, I just wanted to say how exciting it was to have the opportunity to hear about the Public Health Corps rollout at health and hospitals. And I particularly really appreciate hearing directly from the CHWs about just the incredible work they're doing, the amazing successes, along with some of the heartbreaking challenges. And really, I just want to say thank you to your whole team, and kudos and congratulations. And yeah, just thanks so much for sharing the work that you've been doing. And I hope we can figure out a way to have an update, maybe next year. So yeah, thank you so much for joining us today. I did want to thank the rest of our team at the Community Health Workers Center, as well as our co-sponsors. And I wanted to remind everybody 2 things. One is we have a survey, which I think Dina just dropped in the chat box. Just a short anonymous survey really helps us figure out what kind of events to plan in the future and how we're doing. And also please join us in 10 short minutes for our final panel of the day, which will also be about the Public Health Corps, but from the City Health Department side, where they're working in community-based organizations and health clinics. So we'll sort of get a different view of what the Public Health Corps rollout has looked like from their perspective. So there is a link in the chat box to register, and I hope I'll see a bunch of you back in 10 minutes. And thank you again to the whole Health and Hospitals team for just really, truly amazing and moving presentations. Can't thank you enough.
Thanks so much, Amy, and thanks everybody.
Thank you.